Okay. Hi everyone, I'm Hannah and I'm going to be doing a knee assessment on Tafe, one of our fellow students. Tafe has consented to the assessment and just before we start I'd like to just note Tafe has had bilateral ACLs, so that will obviously be something we're bearing in mind while we're doing his assessment. He doesn't currently have any knee issues or any other problems in those areas. Okay, so we'll get started. So to begin with, what I'm looking at is Tafe's posture. So I'm going to have a look above and below the joint. So I'm going to be looking at his hips and his knees and then his feet. So looking at his pelvis at the moment, he's quite neutral in posture, nice normal lordosis. Coming down to the knees, I can't see any valgus or varus stresses on the knees. And down into the feet, he has got pes plantus feet with slight lateral deviation of the first raise. Which indicates long-term mechanical adaptation, likely related to the pes plantus feet. So, for our assessment in standing, because I find this is the easiest way to make the assessment flow, initially what I would like Tafe to do, please, I would stand him onto his good leg. Okay, so can you stand on your good leg, Tafe? Thank you. And what I'm looking at is any movement around the knee, hip or ankle, looking to maintain the stability there. This looks fine, and then I would also compare it to his theoretical back leg. Okay, so we're looking for any excess movement at the knee or the ankle or the hip, but in this case, all looks fine there. So, thanks Tafe. Now what I'd like you to do, please, is if you can stand on your back leg, I would like you to do a single leg squat. So here I'm looking at glute function, ankle stability, good, and knee movement. And I'll ask Tafe, do you feel any discomfort or any pain there? Because he's got nice glute control. That's great, thank you. Any problems?
That's fine.
Good. As with all these tests, I would always compare the good to the bad, but due to time constraints, we're just going to go with the bad one for today. So, Tafe, can you please go into a squat position, so feet shoulder width apart, and squat down for me, please. So that's lovely, thank you. So here I'm looking at the mechanics of his squat. Here in Dubai we do find a lot of people get a lot of issues from body pump, so that can be quite a telltale sign, and it obviously tells us about the patellar movement as well. Last but not least for this set, can you please stand on your left leg again and just do a little bit of hopping for me, please? So here I'm looking for any pain, again mechanics and glute control. Good, stop there, thank you. Now, just before we move on, can I get you to have a little walk up and down towards me? Sorry, Tafe's going to go off camera a little bit. Fine, and back. And what I'm looking for here is any antalgic behaviour in his gait. Thank you. And we can also look at pronation of the feet during that mobility, and if that affects valgus or varus stress at the knees. In his case, that doesn't at the moment. One specialist test just before we go into supine position, so Tafe, if you don't mind coming to me, please. I think we say the Thesali test. So we're going to do it initially with the straight leg on the good leg. Thank you. And what I'd like you to do is twist your hip. So 3 nice, fast, yeah, a bit faster. That's it. 1, 2, 3. Any pain or problems there?
No.
So let's go on to the bad leg, or the theoretical bad leg. And 3 here, please. 2, 3. Good, that'll do. And then we go into a 20% flexion. So, turning. 2, 3. And again, we're looking for, stop there, thank you, any clicking, giving way, pain. Lovely. Tafe, could you please have a little sit on the bed for me? So, a bit old school, but this is how generally I'm testing quads and hamstrings. So, good leg first, nice big push, straightening the knee there. Good. I can also feel for any crepitus here through the patella during that motion. Pulling back, pulling back, pulling back. Lovely. And the same on this leg. So body's nice and close, I can get a good amount of resistance and pulling back. Good, lovely. So that all feels fine. I'm now going to ask Tafe to have a lie down, please. Please excuse me, I'm just going to have to move the camera, otherwise you won't see anything. So we're just going to set that up there. Okay. So to begin with, sorry. Okay. So initially having a look at Tafe's knees, we can see there's bilateral scars from the old ACLs. We've got a little bit of psoriasis on the knees as well, so that's just something to bear in mind. I'm looking for any swelling, any redness, or any obviously change in skin texture left to right. We can also look at this point to see if there's any muscular atrophy, which we can measure with a tape measure objectively by going 4 inches superior to the patella and then doing the circumference. But as for tape's sake, I don't feel like I need to do that. So, to check for swelling intracapsularly, I can do the sweep test. So I'll be sweeping up through the knee there and then applying a downwards pressure inferiorly on the lateral side of the knee. And we're looking for any small little bump of fluid that just appears on the medial aspect of the knee there. Luckily for us, tape doesn't appear to have any of that, so that's correct. What we're going to progress on to now is I'll have a look at the range of movement and then we'll go into the patella. So, Tape, can you please bend your initially good, well, we'd ask him to do good leg first, but we'll just stick with this one for now. So good leg up as far as you can go, and we'll compare to this one. Lovely, thank you. Is that as far as they go?
Yeah.
Any pain or any problems?
No.
Perfect, okay. Can you straighten your legs out for me? Okay, now what I'd like you to do is look at extension, bring your toes towards you, and squeeze your knees down into the bed as far as you can go. Now at this point you can use a goniometer to measure, should be 0 on both sides, okay, and this looks fine. In this position I can also see the toes got nice vastus medialis oblique activation and vastus lateralis. Just relax that tape for me please. One of the tests I like to do is looking at the movement of the kneecap on contraction. So to do that I stabilise the kneecap, place my finger on the middle of the superior pole of the patella and get him to squeeze his knee tight, so squeeze down into the bed, good. And then I can see the activation sequence of the quad, so I can see that the VMO there is kicking in primarily with subsequent activation of the vastus lateralis. So that's super. I'm not going to do it in this presentation, but just as a heads up, normally with anterior knee pain I find most of the time the knee isn't actually the problem, it usually comes from the hip. So I normally do a Thomas test, an Overs and a popliteal angle test to cover quads, psoas, hamstrings and ITB to make sure that none of those structures are giving the knee any issue or causing the pain. But for the purposes of this examination we're not going to do that. So moving on to the patella, I'm going to have a look at the patella movement. So I'm gliding the patella medially and laterally. I'm going to glide it superiorly and inferiorly. I can also have a little palpate around the whole circumference of the patella there and say to Tape, is there any pain there, any discomfort?
No.
No? Perfect. Obviously again we compare all these movements to the good side. Again, patella tendon, I'll be looking at palpating, so the inferior pole of the patella, and palpating onto the patella tendon there. Now bearing in mind that there's a very highly innervated bursa at the base of the patella pole, we just need to bear in mind that it's going to be uncomfortable. So when I palpate there, say, does that feel the same both sides, Tape? Is there any pain there?
No.
No, perfect, okay. And last but not least, with the patella testing, we can do, sorry, not last but least, we can do patella compression, okay, to see, I don't think Tape likes this one, to see if there's any discomfort when the posterior aspect of the patella becomes in contact with the femoral groove. And we're looking for pain provocation there. And this is the last one, for me anyway. You can also do the patella tap test. So if there was any swelling present, you would gently guide it down towards the patella and then tap the superior element of the patella to see if you're getting any tapping there to highlight any swelling posterior to the kneecap. So, thus far we don't seem to have any problems with the patella, which is fantastic. So what we're going to do now is we're going to move on to the ligaments. Now, to look at posterior cruciate ligament initially, I get Tape to bend both knees up, and again all these tests are done ideally first, good leg first, and followed by the bad leg, as it gives us a good indication of what is normal and any abnormality on this side. So, in this position, if there is no intact PCL, a lot of the time you can see a displacement of the tibia. If not highlighted in this position, we then bring them into 90 degrees there, ask them to relax, and often you'll find that the tibia will posteriorly locate onto the femur there and you'll get a little drop down. However, if none of that shows, okay, you can straighten that one, thank you. I can do the posterior draw test. So I'm going to put my thumbs on the tibiotuberosity and I'm going to apply a forceful posterior thrust, okay, onto the tibia there. And I can feel quite a firm end feel there where we're catching at the end of the ligament laxity. Okay, so we're assuming nothing's wrong there with TAFE's PCL. Moving on to ACL, in this position, quite nice, we're doing anterior draw, so similar position, okay, and this time we're doing a nice thrust in the anterior direction and feeling for the end range there of the ligament. I would always compare the good one to the bad one, because it gives you a very good indication of their normal. So luckily for TAFE, that feels fine, but progressing on to a more specific test for the ACL, we look at the Luckmans. Okay, so I put my thumb on the tibial tuberosity, my hand posteriorly on the tibia, stabilise the femur with the knee in around 30 degrees flexion, and I'm just going to gently draw the tibia towards me. If that's positive, you feel the glide quite obviously in most cases. But luckily, again, seems negative. So, MCL. Both hands I'm placing on the tibia, knee in, again, around 30 degrees flexion. We don't do it in straight because you don't get a good reading, and bent is well bent is too difficult to control. So all I'm going to do from here is a nice little sharp movement into the medial knee, and there's no give there, which is great. And similarly for lateral, but this time I'm giving it a lateral thrust. And again, I would always compare good leg to bad leg. So, all looks fine in terms of ligaments. Moving on to meniscal. Typical meniscal pain is usually located immediately to the joint line, and some research does show that that is one of the most sensitive tests is the medial meniscus pain on palpation. For the purposes of testing, we've obviously already done the specialist test in standing. In supine position, you have the two variations of the McMurray, so stabilising the femur there, okay, turning the foot externally, winding the joint up and rotating through there. And we're looking for any clunking or clicking, internally rotating the foot there and going through your figure of 8 movement. Any clunking, clicking or pain will take? No, good. The other variation on McMurray's is tibial internal rotation, okay, applying that pressure through flexion and extension, again, and awaiting any clicking, clunking or pain. Similarly, external rotation of the tibia there, whoops, sorry, any clicking or clunking there. And that feels okay? Yeah. Fabulous. So, if we found anything positive there on the meniscus, we could progress to Astley's grinding test, which is the last one I'm going to do for today. So if you'd like to have a turn on your tummy for me, please, Dave. Okay. So for this test, you have the patient in prone, stabilise the foot, okay, and the tibia, and all we're going to do is put a little bit of pressure on there to compress the joint, and we're going to have a turn and see if we get any grinding, any pain in that position, okay? Anything there?
Feels fine.
Feels fine, good. Luckily for TAFE, nothing there. However, if we did have something positive, what I would do is the distraction element. Please bear with me 1 second. Head. What I would do is then stabilise TAFE's femur, okay? Distract up, and similarly, internal, external rotation. Feeling for any clunking, clicking or any pain. If you're getting pain on compression or any clicking, grinding, generally that's indicative of meniscus. And similarly, if you then decompress it and you don't have any symptoms, indicative of meniscus, but if you get pain with both, it's going to generally be attributed to soft tissue. That's my new presentation. Thank you very much. Hope it wasn't too long.